Attendees are in listen-only mode.
Good afternoon, everyone, and welcome to today's webinar. My name is David Kanashko. We'll be starting in about 5 minutes, and I just want to make sure everyone can hear me. So if you can hear me, just send me a little note saying that you can hear my voice loud and clear, and we'll start very soon. Thank you. Okay, I'm going to get started. And once again, my name is David Kanashko. I'm the Director of Education and Training here at BioFlex Meditech International in Toronto. I want to thank you all for joining me today. I want to give a shout out with respect to our upcoming masterclass. It is on Sunday, April the 17th in Toronto, and we're doing a series of topics. We have quite a few external speakers from our experienced BioFlex users, as well as internal speakers like Wendy Skirshimova, our our research director, and of course Slava Kim, Diva Miri, a clinician as well here in Toronto, and Dr. Celeste Thirlwell, a specialist in sleep disorders and laser therapy. So hopefully you can come out and make it. I know sometimes geographically, depending where you are, you may not be able to make it. I'm not sure if the presentations will be available after the fact. Some of them may be. There may be a cost involved as far as watching them. I'm not sure yet. But I will be recording as many as I can, and hopefully I can do something with them for those of you who can't make it. But there's no guarantee, and more than likely there will be a fee. Anyway, let's move on to today's topic, which is laser therapy and diabetic peripheral neuropathy. So before we start, I just want to mention to you that if you have any questions, please type them in, and I'll get them to them at the end of the webinar. And if I'm not able to answer your question, you can always email me, and my email should be at the end of this webinar as well. Okay, so let's get started. I'm going to do a little bit of an overview with respect to the pathophysiology and signs and symptoms of diabetic peripheral neuropathy, sometimes shortened as DPN. Then I'll talk specifically how low-level laser therapy can help with this condition. And I'll discuss some of the clinical research that's out there with respect to the efficacy of laser therapy and DPN. I'll talk a bit about how we approach treatment using our equipment for DPN. And lastly, I'll present a case study that we have from our clinic. And hopefully there's some time for some Q&A at the end of today's session. So before we start, again, I'm just going to double check to see if there's any outstanding questions. It sounds to me like everyone can hear me, which is great. So I shall continue on. So the definition of DPN is, quote, the presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. So it's important to understand here that we're ruling out other types of conditions that might cause a peripheral neuropathy signs and symptoms. And there's quite a few, obviously. For example, compression of nerves at the level of the spinal cord, exiting the intervertebral foramen, or other entrapment areas as well too. So all that has to be ruled out in order to make this type of diagnosis. The cause of DPN are multifactorial. There are some metabolic factors that may cause this problem, especially in diabetics. We're talking about increased or prolonged increased blood glucose. This will decrease the sodium-potassium pump, reduce the output of ATP, and decrease nitric oxide levels. As well, increased blood fat levels and low insulin levels have a role to play as far as the metabolism of nerve cells. Then there are specific neurovascular factors, which is probably the most important aspect as to how laser therapy might help with these patients. Specifically, the blood vessels can be damaged. This leads to decreased oxygenation and nutrients to the nerves. There are some autoimmune factors as well, causing nerve inflammation, as well as mechanical injuries to nerves and lifestyle factors. For example, mechanical injuries would be prolonged weight bearing on the feet that might cause damage to the nerves. Lifestyle factors, for example, they know that smoking and excessive smoking and alcohol can also cause insufficiencies in nerves as well too in these patients. So basically what you're looking at here is you're looking at a normal healthy cell, nerve cell at the top in the axon with the myelination secondary to Schwann cell proliferation. And the second diagram you can see is the area of damage that we're interested in helping to heal, the scarred myelin sheath that reduces the ability of the nerve cell and the axons to function. So a nice little diagram to show this is on the left, a nice healthy nerve cell with healthy blood vessels that perforate and go throughout the nerve bundle, allowing the nerves to get their nutrients as well as excrete their waste products. If these if these blood vessels are damaged, so you can see here there's an occluded vasa nervorum, then that will lead to decreased circulation within the nerves themselves and eventually lead to decrease function of Schwann cells and the axons and the function of the axons because of damaged myelination. Okay, so with long-term diabetics, you're looking at a scenario on the right where you start to have decreased function of the actual nerve bundles. It's a progression. So at the top is a normal a normal nerve axon with the blood vessels, and then as the blood vessels become diseased, they start to withdraw, or they actually start to sort of die off, and eventually these nerves and these axons are not at all, the vascularity is decreased, and the ability to actually transmit is vastly diminished. So this would be an end-stage scenario where the patient has ongoing diabetic peripheral neuropathy. There are some different types of DPN. There's sensory motor. This is an acute, one type of this is acute reversible. So this is when the glycemic index spikes and can cause a temporary neuropathy. It is temporary, so we're not so much concerned about this, as we are more concerned about a persistent type of sensory motor DPN. There's both symmetrical and focal and multifocal forms, as well as autonomic types that affect the autonomic nervous system, obviously, that affect sweating and erectile dysfunction. It can even lead to Charcot arthropathy and neuropathic bladder. Today I'm going to talk more about the more common form, which is that symmetrical persistent type of DPN. So signs and symptoms of DPN, typically it's the lower extremities that are affected the first, and followed by the upper extremities. So you're looking at symptoms that are usually worse at night and typically involve numbness or reduced ability to feel pain or temperature changes. So a appropriate neurological assessment would need to be done. Oftentimes a patient complains of tingling or burning sensation in their feet or their lower extremities, and they'll have sharp pains or cramps as well too. So that's the typical sort of sign and symptom pattern for DPN patients. They also have increased sensitivity to touch. They may have muscle weakness, loss of reflexes, most notably in the S1 ankle reflex. Oftentimes there's balance issues and coordination issues, and with prolonged chronic issues, the patients might develop ulcers and infections, joint pain and bone issues as well towards the end stages of this type of condition. So how can laser therapy help? Well, I'm going to first talk a bit about how it can help with angiogenesis and neovascularization. So let's talk a bit about this. What you're looking at is a picture of a lymphocyte, a T cell specifically. If these cells that are circulating in your blood are irradiated with low-level laser therapy, it stimulates them to release a series of different types of interleukins and chemical mediators. You can see the names or the acronyms like vegetative growth factor and metalloproteinases and integrins, follicular growth factor, and so forth. So if you irradiate blood for a prolonged period of time, then these lymphocytes will start to secrete these different types of positive mediators, which will lead to angiogenesis. Okay, the key here is prolonged irradiation of the blood. You won't achieve this effect by treating in a very quick manner. That blood needs to be treated for quite a few minutes for this effect to have a systemic effect. So essentially what happens is this is a capillary, and what we're trying to do is improve the ability of this capillary to have growth. Okay, so we're looking at new branches being formed. So what happens initially is VEGF and follicular growth factor stimulates the beginning of the formation of branches of the capillary. So the next step is basement membrane degradation by MMPs. And this will then stimulate the endothelial cells to proliferate and migrate and actually start to form tubes or branches of capillaries. So over a long period of time, the stimulation of these white blood cells has an effect on actually making new blood vessels or branches of these blood vessels, which of course will help within damaged nerves because of diabetes. So the more blood flow you have, the more branches of capillaries in these neurovascular bundles, the healthier these nerve cells will be, and of course they will start to function much better. So again, the first step is try to irradiate the blood, specifically these T cells, that will help promote endothelial growth and branches of capillaries to help with blood supply of the nerve bundles. Okay, so what we're trying to do is take, on the left, damaged neurovascular bundles, and over a period of time, we're talking weeks if not months of treatment, we're trying to restore the ability of these nerves to function by improving their circulation. So that was angiogenesis and neovascularization. Laser therapy can also help by reducing inflammation and edema, which again helps this type of condition to heal. The anti-inflammatory effects involve the release of things like inhibiting PGE2 or prostaglandin, which is a major inflammatory mediator. It will decrease inflammatory cytokines like tumor necrosis factor and interleukin factor 1 beta, and increases anti-inflammatory cytokines like interleukin 4 and interleukin 10. It also decreases something called COX-2 or cyclooxygenase. So altogether, these have an anti-inflammatory effect of the tissues that are inflamed. I should note that what we're trying to do here is directly treat the area with light. Okay, so it's important that the area that is affected, the actual lower extremities, are treated with light and not just the origin of the nerves in the spinal cord. And I'll talk a bit about that when we do a case study. Next, specifically, I'm going to talk about how the nerves regenerate themselves using laser therapy. And I'm going to actually relate this information through some research. This particular paper called Effects of Early and Delayed Laser Application on Nerve Regeneration. And their findings clearly supported a biostimulatory effect on nerve regeneration. They were able to show that laser therapy initiated the proliferation of astrocytes and oligodendrocytes in the nerve cell. It reduced oxidative stress, which is a potent pathological factor that leads to tissue fibrosis, as well as increasing the production of fibroblast growth factor, which again helps for the tissues to heal. Okay, so the morphological analysis of the nerve indicated that laser therapy had a capacity to reduce the migration of mononuclear cells to the damaged nerve, those are neutrophils, leading to decrease in edema areas and rapid regeneration. So there's a nice body of research out there. This is one paper that indicates and shows how laser therapy can help with nerve regeneration. At the masterclass, I'm going to be presenting a case study of a patient of mine that had his hand unfortunately put into a piece of machinery that he was operating and had significant nerve damage in his hand. And we've been able to help him extensively after surgery with repair of the nerves that when he came to us had really shown no signs of improvement for quite a few months. So laser therapy can stimulate migration and fiber sprouting of neurons. This is a paper done by Shimon Roshkind in 2009. You can see a control neuron at the top with the axons, and then you can see another example of a neuron that was treated with laser therapy, and you can see there's a lot more sprouting occurring from the neuron. Okay, so we're actually able to improve the number of axons and sprouting in neurons when they're exposed to laser therapy. This, of course, helps to improve the interconnection network of neuronal fibers. Okay, the arrows just are pointing to those axons that have been regenerated and formed because of laser therapy. Another way that laser therapy can help is by stimulating Schwann cell proliferation and myelin formation. So on the left top, again, this is a study done by Shimon Roshkind. It's a control. Whoops, sorry, let's go back there. And on the right is the axons that were treated with laser therapy. It's kind of hard to tell, but these areas you're seeing, the sort of white blobs, or when they're cut in cross-section, are the areas of myelin around the axon sheath. Okay, so we know that Schwann cell is one of the targets for laser therapy to improve myelination, which, as I told you earlier, is one of the key problems of DPN because the myelin starts to degrade. Okay, so what does the research say about diabetic peripheral neuropathy and laser therapy? This one study was done not too long ago, and they looked at 17 participants. They were diagnosed with type 2 diabetes and diabetic neuropathy. They did nerve conduction studies to confirm that neuropathy, and then the patients received 3 times a week for 10 sessions of laser therapy. They were then reevaluated with the completion of the treatment. At the end of the study, the subjects showed a significant increase in neural potential amplitude, so they did that nerve conduction study again. This study clearly demonstrates a significant positive effect of laser therapy to improve the nerve conduction velocity. So it's a very objective measurement, not just subjective by the patient, but they were able to actually measure an improvement of the nerve conduction. Okay, so again, papers like this help to support the therapeutic potential of laser therapy in diabetic peripheral neuropathy. Another paper looked at 60 patients that had DPN, and they were randomized both to case and control groups, and they looked at their visual analog scale along with Toronto Clinical Scoring System for diabetic peripheral neuropathy. The patients received laser therapy twice a week for 1 month, and during that same time frame, the control patients received sham laser therapy. And here are some of the results. You can see these are the patients that received laser therapy, and you can see the VAS before the first intervention of laser therapy was at 8.17 millimeters, and then after 2 weeks of treatment down to 6.2, and after 4 weeks down to 5.9. And on the Toronto scale, they started at a 9.93 and then eventually down to 7.87. So again, significant statistically relevant improvement in patients that receive laser therapy. Sometimes I forget I put these fancy little red things. Okay, so our approach. Our treatment is focused over the lumbosacral region, the sciatic nerve pathway, and the extremities themselves. We try to treat all the affected areas. So we're going to place the arrays over the lumbosacral region and lower lumbar spine. And we're going to also place the arrays over the exiting nerve roots bilaterally. Again, most of these patients have bilateral symptoms, so we're treating both sides. And we also do another placement that focuses even more infrared light over that lower lumbar spine to try to improve the treatment, or try to get even more treatment in that lower lumbar spine. Then as far as the laser probe goes, well, for the lumbosacral region, we want to not just treat the lumbar spine itself, but we want to follow the pathway of the sciatic nerve. Okay, so don't forget to treat all the way down the path of the sciatic nerve if possible. Make sure that you push the probe in into the muscle tissue, disperse as much tissue as possible, and blood, of course, because that allows the light to get closer to that sciatic nerve, and hold that for at least 15, if not 20 seconds in one spot before you move it to the next spot. Sorry, so this will actually help the nerve, it will have an additive effect on the actual sciatic nerve itself. When we're treating the lower extremities, we're going to treat typically the foot. That's usually where most of the signs and symptoms are occurring. And we're going to treat both the plantar and dorsal aspect of the feet. All right, so I have about 5 or 10 minutes left to do a case study that we did here in Toronto. The patient was a 67-year-old diabetic accountant, had numbness and tingling sensation and progressive burning sensation in his forefeet for the past 10 years. So there was concern over a long-range implication because his condition was worsening. He had several medications he had tried or was on, including metformin and Lipitor and Ramipril, along with some other medications. He was also having a bit of chronic back pain with no radiation, so more probably mechanical pain. Upon presentation, his lumbar spine was about 70% of normal, so not too bad. However, he did have hypoactive reflexes, especially S1, and sensory tests indicated poor sensation over the lower extremities. His motor of his lower extremities were okay, so it was advanced but not seriously advanced as far as affecting the motor nerve system. So we actually referred him out for nerve conduction testing on the sural and peroneal nerves bilaterally, and it came back as sural nerves had a latency bilaterally, and the technician and the doctor indicated that there was a sensory polyneuropathy of the sural nerve. Okay, just a reminder where that sural nerve is and its innervation from S1, S2, affecting the posterior calf and down into the heel and over the lateral aspect of the foot, over the fourth and fifth toes and into the plantar surface of the foot. Okay, so we started treatment both of the lumbar spine and the lower extremity. For the lumbar spine, we started with a continuous wave. Here we're trying to really affect the circulation with the red light. It doesn't penetrate very deep. We treated about 6 minutes overlying those areas I showed you earlier over the lumbosacral region and lumbar spine and bilaterally. For infrared, we used 50% duty cycle, so that's half the amount of power that we can emit with the infrared light, and we used a pulse frequency of 50 hertz. We used a higher intensity laser diode probe. However, we set that at 40%, so that was roughly 80 milliwatts, and we used that for about 10 minutes over the areas I mentioned earlier. Okay, and at the bottom you can see the placements of the red, and then the infrared we did an extra one. You can see an extra 6 minutes to again intensify the infrared light, hopefully going a little bit deeper around that L5, S1, and S2, which of course we know is the main problem here as far as the neuropathy. By treatment 3, the patient was starting to show some improvements. However, there was a bit of a plateau. So you can see in red what we did was we increased the duty cycle to 70%. So roughly we increased 20% the dosage of the infrared light, and we went all the way up to 200 milliwatts, so 100% continuous wave with a laser diode probe. Again, the thoughts here are to try and get as much light as possible. The patient seemed to have plateaued to some degree, and by increasing the amount of energy, especially the infrared, to get a little bit deeper and hopefully affect the sciatic nerve and the nerve roots, we're able to stimulate that nerve even more so. By the 6th treatment, again, the patient was progressing and showed a slight plateau. This is where we started to alter the frequency, or actually have a frequency for the red light at 100, duty cycle of 90. I oftentimes get asked the question is the importance of pulsations, and I'm going to talk a bit about this in the master class and the reasons why we pulse light, and have understanding, a basic understanding really relays the fact that the light that enters the cells and is being used by the cells stimulates, as you I'm sure are aware, the electron transport chain. The cell needs to actually use that light before it can be re-stimulated. So the time gap between the stimulations of light allows the cell to actually use that light and stimulate it to make more ATP. If you have a steady stream of light for a constant period of time, it doesn't seem to be as effective because it doesn't allow the cell to recuperate and to use that energy on an ongoing basis. Okay, and you can see we also increased the duty cycle to 90% for the infrared array. We left the frequency at 50. And by treatment number 8, we start to really increase the frequency of red to 1,000 and 250 for the infrared, and we left the parameters for the LDI-200 probe the same at continuous wave. The reason why we're not pulsing the laser diode portion of it is that laser diode is only in one spot for maybe 10 or 15 seconds. It's not on long enough in one spot to really have an impact for pulsing like the arrays do, because they're sitting there for 6 minutes in one spot. So therefore, if you're pulsing that light with the arrays, that means you're able to stimulate the cells on an ongoing basis over that tissue that's being irradiated for a continuous period of time, whereas a laser probe, you're moving it around a lot, so you're not having it in one spot for, like with the arrays, for 6 minutes. Hopefully that makes sense. Okay, so we also treated the lower extremities, in this case the feet, and we started off with, again, 6 minutes using red continuous wave. In infrared, we used 50 hertz cycles per second, 80% duty cycle. We used 100% 200 laser probe for 6 minutes overlying the foot. After treatment 4, again, we're starting to see progress with some plateauing. We started to modulate the red light to 190. Infrared increased the frequency substantially to 250 and to 90% duty cycle. So you can see here the duty cycle is at 90, which basically means we're at 90% of the total maximum amount of power. What we're starting to really change is the frequency to help stimulate the cells and the tissues even more so for that explanation I mentioned earlier. By treatment 8, we increased the frequency even higher to 5,000 for red and 1,000 for infrared. These numbers you don't see too often, but we find when you're dealing with nerves and simulating nerves, oftentimes you have to really increase the frequency to help with the stimulation. Okay, so the outcomes. After the series of treatments, we sent that patient out for another nerve conduction test, and with that treatment, that nerve conduction test came back negative. That is, that left and right sural nerve was within normal limits. So we were able to restore the function of that sural nerve, the S1, S2 nerve roots, using these types of techniques. All right, so here's my email, david@bioflexlaser.com. If you have any specific questions about today's webinar, I have a few minutes left, so I'm going to take a look to see if anyone has any questions right now. Okay, I don't see any questions. So if you do have anything, let me know. And please, if you have a chance to be able to come to our masterclass, it's here in Toronto, April 17th. It's from 9 a.m. till 5 p.m. Registration and breakfast and lunch is included. Well, of course, registration is included, but breakfast and lunch is also included. And you can find all the details on our website as well. Thanks very much. I appreciate your attendance. And I'll be posting the new series of webinars next week for the next few months. Take care and have a happy Easter.